Thank you, ma'am. So with this, I would like to welcome Dr. VARSHINI Shankar. She is alumni of Shankar Netralaya, and we did fellowship together. She is working in pediatric ophthalmology, strabismus, and neuro-ophthalmology at Shroff Eye Center, Delhi. Her talk will be on neurological lesions causing unexplained visual loss.
Thank you, Dr. MRC, for inviting me for this IC and for this interesting topic. So, proceeding from where, so we have done causes of visual impairment where the fundus is normal and CVI, where again, the examination is normal, but it's the MRI which is abnormal. So I will be talking about mainly acquired poor vision in childhood, which can present with an abnormal eye exam and with a normal eye exam. Dr. Rishi has already spoken about retinal dystrophies and of course high refractive errors as the most important cause of acquired poor vision. But I'm going to be talking mainly about CNS causes, which can be demyelinating, it can be infective, and there can be space occupying lesions which are causing vision loss. So starting with optic neuritis as the most important demyelinating cause of sudden vision loss with CNS associations. So optic neuritis is a term used to define an acute demyelinating or idiopathic optic neuropathy. In children, this can present as a retrobulbar neuritis, as a papillitis, and as a neuroretinitis. Etiology wise, it can be idiopathic, it can be associated with certain infectious condition. Children most frequently seen after vaccination and associated with other inflammatory conditions including sarcoidosis and SLE. So pediatric optic neuritis can be differentiated from adult optic neuritis in the sense that the presenting vision is normally very poor, less than 20 by 200 in 60% of the patients, frequently bilateral, up to 72% in children younger than 10 years of age. There is usually a preceding viral illness or a history of vaccination. Many of them present with disc edema. When treated, there is excellent recovery of vision with high contrast visual acuity of better than 20 by 40 in most patients. Even a single episode can cause some residual damage of RNFL loss up to 8 to 10 microns per episode or even more. So coming to the CNS associations, pediatric optic neuritis can be associated with multiple sclerosis. This is most commonly seen when you have more than 2 white matter lesions present in a periventricular area at presentation. On lumbar puncture, CSF oligoclonal bands are frequently positive. NMO spectrum disease is also now being recognized more and more in these patients. These are the patients who present with severe attacks of optic neuritis and longitudinally extensive transverse myelitis. Aquaporin 4 antibody needs to be checked for in these patients. ADEM is now, it's more recognizable and easy to differentiate because it's a polyfocal disease presenting with severe systemic features including encephalopathy, optic neuritis, weakness, gait abnormalities, and paresthesias. The MRI is also quite distinctive with diffuse, large 1 to 2 centimeter lesions in the cerebral white matter. The association of anti-MOG antibody with ADEM is now being recognized. Management, there are no specific randomized control trials for pediatric optic neuritis. So we are working with evidence which we have gleaned from the optic neuritis treatment trial. IV methylprednisolone is given at a dosage of 30 milligram per kg per day up to 1 gram a day for 3 to 5 days. If children do not improve, and this is quite frequent, especially associated with NMO, then a second dose of IVMP can be considered. Second line treatments include plasma exchange, which is also quite effective in children, and IV immunoglobulins. If there is an underlying disorder, then we need to consider prophylactic therapy to prevent further episodes because there is damage at each episode as well as immunosuppression. The common drugs which are being used now are mycophenolate mofetil, azathioprine, and increasingly rituximab. So this was a 16-year-old boy who presented with sudden onset blurred vision sequentially in the left eye followed by the right eye after 3 weeks. He had about 6 months earlier a previous episode of lower limb paresthesia and gait abnormality which recovered spontaneously. At the time of presentation, his right eye visual acuity was 6 by 24, left eye was hand movements close to face, color vision was impaired, there was a sluggish pupillary reaction, and the fundus and optic disc was completely normal. The VEP showed a delay in P2 latency with very low amplitudes in both eyes, suggesting an bilateral optic neuropathy. When the patient was imaged, as can be seen over here, he had bilateral enhancement of the canalicular portion of the optic nerve. But what is striking is the chiasmal involvement and enhancement, along with involvement of the right optic tract as well. So this kind of long segment involvement of the optic nerve and visual pathway should kind of alert us that maybe there may be an associated underlying CNS condition as well. The MRI of the spine was normal in his case with no demyelinating lesions. He was CSF analysis was normal. There were no oligoclonal bands. The anti-MOG antibody and anti-aquaporin 4 antibody was negative in both CSF and serum. He was started on IV methylprednisolone at 1 gram per day for 5 days with partial improvement, at which point this visual field was done with showing a dense generalized deficit. Since the patient did not improve too well on IV methylprednisolone and a young child with the characteristic MRI lesions, he was advised plasma exchange therapy. But due to the expense, he opted not to go for it and instead went in for IV immunoglobulin therapy. He had a partial slow improvement, was maintained on steroids for some time, and after which he was eventually he's being maintained on injection rituximab, which is a anti-CD20 monoclonal antibody. He had slow improvement of vision till 6/6 with a normalization of the visual fields, but as I mentioned, with the residual GCL IPL thickness loss, showing the residual loss which he's had from this first episode of optic neuritis, and again a very young child, so these patients need to be tackled extremely aggressively. We cannot leave them just with IVMP as we normally do for optic neuritis. So after demyelinating, infective causes of vision loss in children, and in India, infective causes of vision loss is predominantly tuberculosis related, and tuberculosis can cause vision loss in children in a myriad number of ways. It can directly affect the optic nerve, causing optic neuropathy, can present as an optic neuritis, optic perineuritis, increased intracranial tension presenting as papilledema with secondary optic atrophy, presenting as vascular occlusions including AION and CRVO, presenting as posterior scleritis, as an orbital apex syndrome. It can directly affect the posterior visual pathway, causing cortical blindness. The basal exudates, vasculitis, and infarcts can directly affect the posterior visual pathway. Once ATT is started, you can have a paradoxical hypersensitivity reaction to ATT, causing an optochiasmatic arachnoiditis, and optochiasmatic tuberculomas can be present. In this image, this was of a young child with multiple ring enhancing lesions, presenting with a normal fundus, bilateral unexplained vision loss. When we imaged, we saw these multiple ring enhancing tuberculomas, with this particular large tuberculoma directly compressing the chiasm, so pretty much acting like a cellar lesion. And as well as we cannot forget toxic optic neuropathy in children as well. Again, these are very young children. Ethambutol toxicity is seen in them. We really need to warn them about the toxicity beforehand, because the visual loss is permanent. And as we get more multi-drug resistant TB as well, we are seeing toxicity related to linezolid as well more frequently than before. So when we suspect ethambutol toxicity, as I said, the fundus essentially is normal, with patient presenting with acute, usually bilateral optic neuropathy, which is difficult to differentiate from optic neuritis. So an imaging is necessary to rule out any other cause of vision loss. The ATT, especially the ethambutol, needs to be stopped immediately, and we need to keep a close watch. If there is no improvement, and if they are at the end of their course, because usually they present at about 4 to 5 months after taking the medication, so at which point the isoniazid also we need to advise that it should be stopped. Coming to other compressive and infiltrative intracranial lesions, these generally, the most common lesions are craniopharyngiomas, gliomas, AV malformations, aneurysms, and arachnoid cysts. These can have a lot of neuroophthalmic manifestations, including bilateral band atrophy, when the compression primarily involves the optic chiasm. They can present with a congenital nystagmus due to early vision loss, seizure nystagmus, especially in cellular lesions, obstructive hydrocephalus, and dysfunction of the hypothalamic pituitary axis. The most common lesion out of these is a craniopharyngioma, which is frequently misdiagnosed as retrovulvar neuritis and psychogenic visual loss. Craniopharyngiomas generally present to the ophthalmologist with some kind of occult vision loss, and we need to have a high index of suspicion to diagnose these. So this is a case of a 7-year-old child who had a history of patching of the left eye for a few hours a day for the last 1 year. At presentation, the visual acuity was 618 in the right eye, 6.9 in the left eye, with a right exotropia. So on preliminary evaluation, I assumed it to be a strabismic amblyopia who was on patching. But when you looked at the fundus, then I noticed a mild temporal pallor, very subtle, but this was confirmed on doing OCT, again a mild pallor. And as ma'am said, a lot of these patients actually have an occult CVI, which is what you think in these patients. And there's like a mild vision loss, mild temporal pallor, general development otherwise normal. But in this case, after counseling and imaging, this child had this huge supracellular solid cystic lesion with calcification. So we referred to a neurosurgeon immediately, but obviously there is some degree of vision and RNFL loss already present. So the earlier diagnosis, the more vision can be salvaged in these patients. This is a second child with almost a similar imaging pattern, but a completely different presentation. So this was an 11-year-old child who had history of headache since the last 1 year, with increased blurring of vision for the last 2 months, presenting with acute vomiting, at which point she was admitted and imaged, at which point craniopharyngioma again was diagnosed. In this patient, we can see on the CT scan the calcification. Presentation imaging looks almost similar to the first patient, but this patient, because there was involvement of the third ventricle, this patient basically presented with increased intracranial tension and a secondary papilledema, long-standing because history of 1 year. So by the time the child was evaluated and operated, she had already had irreversible loss of vision with secondary optic atrophy in both the eyes. Coming to other more benign lesions which we can see, AV malformations are among the most common cause of spontaneous intracranial hemorrhage in children, generally present with a triad of hemorrhage, seizures and recurrent headaches. Treatment is by surgical resection, may require embolization of the feeding channels as well as stereotactic radiosurgery. They can present again with a wide variety of visual field defects, alexia, congenital homonymous hemianopia, band atrophy, papilledema, ocular motility deficits, and seizures. So this was a 7-year-old child who presented complaining of flashes of light, colored halos, so suggestive of seizures, with sudden loss of vision in one eye and facial asymmetry. The child had herself noticed a bruit of the neck. When the child was imaged, this was noted. So had a huge vascular lesion in the right CP angle and jugula fossa. Multiple connecting channels were noted between the common carotid artery, the external carotid artery, and the internal jugular vein. And you can see this huge dilatation of the common carotid artery here, which was probably responsible for the bruit. So the patient was diagnosed to have a glomus jugulare and advised radiotherapy. On ocular examination, we found this as the fundus picture, where the child had a very unusual ischemic optic neuropathy, obviously because of occlusion of the ophthalmic artery, as well as a right seventh nerve paresis. So in these patients, obviously we cannot do much to salvage the vision. Another similar patient, a 15-year-old with a history of sudden onset holocranial headache, loss of consciousness and seizures, presented with was admitted in an emergency and was diagnosed to have a diffuse acute subarachnoid hemorrhage in the bilateral superior cerebellar region. The child underwent a decompressive craniectomy with evacuation, left frontal VP shunt, and had to have a tracheostomy and was put on a ventilator for about 15 days. After which the bleed was diagnosed to be secondary to a left superior cerebellar AV malformation, which can be seen in the first photograph, this nest of vessels over here, which was embolized, and we can see the resolution of the same. But as a result of which, by the time the child came off the tracheostomy, she had a problem with speaking, with a problem with focusing, and a problem with gait, and was confined to the wheelchair and had to have extensive physiotherapy for the same. So by the time she presented to an ocular for an ocular examination, she came with a history of sudden vision loss 5 months later after this episode, with a visual acuity of 630 in the right eye, 624 in the left eye. Had a variable pseudomyopia in both eyes with a lead of accommodation on MEM. And this, so the child had a very characteristic downbeat nystagmus secondary to the cerebellar lesion. So I treated her pretty much as we normally treat a spasm of near reflex with atropine eye drops and progressive glasses. But the child had multiple relapses on attempting to wean, and ultimately we could wean her off the atropine after about 18 months. So in this case, we are not really very sure of what the etiology was. As we know, many of the spasms of near reflex can be organic as well, especially secondary to head trauma, secondary to cerebellar disease. But in this case, it could have been functional as well, because the child had had depression following the episode and on being confined to a wheelchair. So we are not really very certain of the cause of the spasm of reflex, whether it was functional or organic in her case. So I would like to conclude by saying many neurological lesions can present with subtle as well as sudden vision loss, and a high index of suspicion is required in these patients, and a multidisciplinary approach to salvage whatever vision we can. Thank you.
Thank you, Dr. Varshini. Thank you for sharing interesting cases. I think